Welcome to the Physician Associate Podcast.
Hello and welcome to this episode of the Physician Associate Podcast. My name is James and today I'm delighted to be joined by two guests, Mark Reynolds and Bob Spoor. Welcome to the show both. Mark, do you want to introduce yourself first?
Yeah, I'm Mark Reynolds. I'm an associate clinical educator, also a role player, but mainly these days just working in the associate clinical educator role. And these days working primarily with physician associate students.
And I'm Bob Spoor, founder and director of Meducate Academy. We provide the healthcare industry with associate clinical educators like Mark. I too am an associate clinical educator as well as a medical role player, and I've been doing the job for over 12 years now. Working in a variety of fields, everything from pharmacy, dentistry, through to medicine, and more latterly, really with the physician associate program.
Perfect. Thank you both for coming on the show. I've just, in my own developments, just done a postgraduate certificate of medical education. So I'm really interested in how students learn and how we can teach PA students of the future better. And I came across you guys through mutual contact and was talking about how PAs are trained and was really interested to find out a little bit more about the simulation training that you used for physician associate training. Do you want to explain a little bit about how you first got involved with PA education?
I can, from my point of view, I got involved through the University of Birmingham Medical School. So I started off with medical role player. I was then recruited by Professor Jim Powell, who set up the ACE program specifically at Birmingham to help physician associates develop using simulation, but using high fidelity simulation in the sense that we were trained to give feedback to the individual students about their technique when they were doing, say, for example, a cardiovascular exam or a respiratory exam or cranial nerves. It's expanded since then. And that's how I ended up doing what I'm doing. 4 years ago, I set up Meducate because I felt there was a real need from other universities outside of Birmingham to have access to this resource. And that's what I've been doing the past 4 years.
If anybody's interested in listening back to Professor Jim Powell talk about the early days of his course that he set up, there's a podcast episode we did with him. I think it's episode 28 of the first season for PA Week. And it's very interesting to hear Professor Powell's thoughts on the early days of the profession and what the future might hold as well for PAs. He's been very influential. So
he certainly has.
He's a good guy.
For people who have never heard of this associate clinical educator role, the ACE role, they might think they know what it is because they might have had patient actors who come into their university courses and work with them as students. But it's my understanding it's a little bit more than that role, isn't it? How do you explain what an ACE, associate clinical educator, is to the uninitiated?
Right. So the ACE role is usually somebody who's worked in the role play sector, so has an understanding of medical role players as a sort of baseline. That's happened to all of us, hasn't it?
Yeah.
And then they take that person and create a lay educator because they teach that person the body system examinations. So we're all trained to know how a cardiovascular examination is carried out, respiratory, GI, cranial nerves,
upper and lower limb
neuro, musculoskeletal, and others as well. And we are trained in those templates by academics to know exactly how they are carried out and exactly how they will feel when they are carried out correctly. So then we can work with physician associate students. They can work on us on those body system examinations, and we can ensure that they're doing everything correctly because we know the examination when it is carried out correctly. So if they make mistakes, if they make errors, we can bring them back in and say, look, when you did this, blah, blah, blah. We can also help with, so we say, patient comfort. So if they make us feel uncomfortable either with their language or with their technique, for example, if they palpated too deeply during the GI exam, we can flag that up as well. So that's the idea, that we are lay experts in the body system examinations. And because we have a role play skill as well, then we can do a full patient simulation. They can take a history from us, they can examine us, and then they can give us a management plan afterwards. And we can feed back how it all went. because we also have an understanding of clinical communication, how that is carried out correctly, as well as everything else. So we are that, basically. We are lay people trained in the medical models.
Fantastic. And it's worth just highlighting again, as well as being able to instruct and perform the physical clinical examination, you're also able to do the consultation skills training, for example, on the angry patient, the young patient, the suicidal risk consultation, those kind of things as well.
Absolutely, yes. Yeah. So
and we've had a lot of experience in medical role play. So, challenging behaviours, all of this sort of thing is our bread and butter. In fact, all of the ACEs that we're currently training, have all had a medical role play background. They have to have.
Originally, the role of the ACE was seen as a patient perspective. Obviously, a patient who knows what's going to happen, because Bob and I are trained in all the body systems. Therefore, we can feed back to the physician associate student how well they've carried out those body system examinations. As time went on, I think Bob will agree with me here, we more and more embraced the educational aspect of it and started really to kind of teach part of the student training. And now I think, from my point of view, I feel very much involved in the training of clinical communication for PA students, and also the body system examinations now. And Bob and I have upskilled ourselves really to a point where we can be trusted to kind of formally teach the basic body system examinations, which wasn't how the ACE role was originally conceived, but it's something that we've achieved through our work and studies of our own.
Yeah, we have put a lot of work in it at a personal level to ensure that the students involved get the best possible experience without the pressure of having an academic overseeing it, because that can be quite daunting at times.
But the one thing we will not do, we will not teach pathologies. We won't teach the students why they're doing anything. That's for the academic team to teach. We never obviously cross that line. We just teach the examination techniques. How good their palpation is, for example, how well they found the heart sounds in the cardiology examination, for example. But we'll never teach them why they're doing it. That isn't our role. We don't cross that line. And also we can simulate certain pathologies quite easily. Once again, stretch the student, I mean, honestly, I kid you not, I was asked to role play quite a young person last week on a PA course to give the students some idea of how difficult it was to work with a non-compliant patient. It's obviously smaller children are not very compliant with examinations. And there's me, a 55-year-old man, playing a very small child. I was told very convincingly, just to stretch them, make them work harder. It was bizarre, but good fun.
I know some universities use each other to test, auscultation. They'll auscultate on each other and percuss. But at the initial stages, as you probably remember, you don't really know yourselves. So it's a bit of the blind leading the blind. So we sort of fulfill that middle role of we're better than role players in the sense that we've got these physical skills, but we're not going to discuss pathology. Speak to the clinicians for that.
But we support the academics because, of course, they can trust us to work a room. Once they've formally gone through the respiratory examination, for example, they can trust us to carry on with the teaching, and they can do whatever, and trust us to lead the session. I mean, for example, this is a typical week. Last week, I was asked to demonstrate a shoulder examination, and there was a GP in the room. The academic was a GP, and he was happy to watch me do it, and he was smiling all the way through. So obviously, I was getting it right, So we're part of it. We're part of the PA training. We add value to it. And I think we're quite supportive as well, aren't we?
Oh, yeah. The other thing is, we both started life as actors, so we're quite good performers. So we enjoy working a room.
Yes.
So we're very confident about what we're doing, but we do know our limitations.
Yeah.
And we want the students to have that same confidence when they walk into an OSCE. So another part of the job, which is we never thought would happen, was we help the students build confidence in their ability to do the examination in a way that is systematic, is safe, and of course ticks those boxes in the all-important OSCE. And it's not just about the OSCE, obviously. We want to produce safe practitioners, as I say.
So that's really interesting. Neither of you are clinical by training with any formal clinical qualifications, but you've become almost sort of expert patient simulation actors and instructors on how to perform an examination. It's something I often see with students I've taught as well, is they kind of first have to learn the script, if that makes sense. They have to know what they're doing, where to place their stethoscope, what to say to the patient in the right time. once they can get that out of the way, their brain can then flip into learning the medicine and why they're doing the examination that they are.
And that's the role we fill, that little thing where this is how you do the examination. It's almost like a dance. Sometimes we say it's like a dance. Learn the moves, then start to understand why you do these things. And then by the time you're a second year, you can start working with hybrid systems. Somebody comes in with a chest complaint. It could be a bit of MSK, could be a bit of rest, could be a bit of CV. We're safe to work with. They can't hurt us, they can't damage us. And if they do palpate too deeply, then we tell them. We can give them guidance on how deep you do palpate the abdomen, how deep do you go, and what's the breathing sequence when you're palpating for a liver edge, for example. The other aspect as well, and because of all this knowledge, and particularly in the climate we live in now where, students are the customer, education's changed since my day. We have to ensure that the customer, the student, gets the best value for their £9,500 or whatever it is. So, we're constantly aware that the students need, to have regular training, good quality training in a way that makes them think, well, this was worth my fee, It's a sad way to look at education. It's not one I agree with, but that's a personal thing. I think education should be free, but it's not. So we hope to add value to the students' experience.
What do you see the advantages of having somebody like yourself as an expert instructor and actor for simulation in education, as opposed to some of these very high-tech SimMan robots that can simulate certain things for...
Well, SimMan can't feedback how well it went, though, can he?
You see, this is the SimMan. I think the SimMan, has a place. Absolutely. We're all important, I think, in the process of teaching. Very expensive, but they do have a place. But as Mark quite rightly said, they can't turn around to the student and say, you pressed too hard there, or you were in the wrong place. You didn't wait until I finished the breath sound on the respiratory exam, for example, or you were percussing in the wrong place. You forgot to tell me to cross my arms so I could access the lungs on the posterior aspect of the back, so the shoulder blades were out of the way. And we can also, the SimMan can't get off the couch and say, let's have a look at the skeleton. And we get the skeleton and pull it in and say, this is what we mean by impingement of a shoulder. Or this is what we mean by, this is what the greater trochanter joint looks like. This is where you should be palpating. And I think Mark can jump in here. We do know what they're looking for in the OSCE because you would agree we've sat thousands of hours of OSCEs, haven't we?
Certainly have, blimey.
We've sat through OSCE after OSCE, hours and hours of OSCE.
And we've seen the typical student errors over and over again, and we can try and steer them away from that, and support them with that.
A simulated, a SimMan or a patient or a volunteer or even a medical role player doesn't really have access to that information. And it's something else that I've been very keen to promote. So the standard of our training is going to equal that of the PAs, of the clinicians. We're going through a process now where we're attempting to get accreditation for the role. And I'm talking with 2 universities about the development of that as what's called a micro accreditation, where the ACEs will be will have an OSCE style assessment to ensure that when they go out to work with the PAs, they're doing the right thing by the student.
You mentioned having sat through thousands of hours of OSCEs and seen probably thousands of students go through. Are there things that students get wrong commonly, or sort of top
absolutely.
tips that you can suggest?
Yeah, I think that the top tip from me is always actually read and understand the question outside the door, because they come in a bit of an OSCE panic and they haven't read the question properly, and they start doing things they shouldn't do, and they don't score any points, and it compromises their performance. So, I always say to them, read, understand the question, use that 2 minutes to make notes on what you want to do when you come in, and just focus on the task, And the other thing I'm always talking about is if you perceive you've had a bad station previously, don't bring that emotional baggage with you, because you get them come in. Obviously, the previous station went badly. They're visibly upset by this. And the trouble is it compromises their performance in that new station. So we also talk about trying to let things go. If you perceive you've had a bad station, try and let it go and come in fresh to the next one. But honestly, I think the success or fail of an OSCE is based on that 2 minutes before they come in. And so many of them don't focus on the task, don't read and understand the task properly, and come in and have problems because simply that, really.
You know, we ran a number of online sessions with the PAs on the course at Wolverhampton to help them understand what is it I'm looking for in the question. What do we do with this question? What's the subtext of the question? They're never trying to catch you out,
No.
but it's a case of actually understanding what is it they require. And me and Mark, I think, can both speak about this with particularly assessments on suicide risk assessment. When they've read the question outside, they know it's a suicide risk assessment. So you're probably going to be coming across a patient who's going to be very upset, very worried, very scared, very anxious.
I know where this is going.
Yeah. And they walk in, they go, hiya, my name's such and such. I'm a second year PA student here at Birmingham. And you go, really? And it's about, look at the patient, you know. So you've read the question, you understand what it's going to be, so you've prepared yourself. 2 minutes is quite a long time to prepare, particularly at the end of a 2-year course when you have that body of knowledge hopefully installed. You know what you're coming into. Just do what's asked of you in that 2 minutes. The golden 2 minutes, as Pete Gorman would call it. It's going to allow you to pass your OSCE. And then look at the patient. And forget the examiners there. You're no longer in a room in a university somewhere doing an OSCE. You're with an actual living, breathing patient. You play your role, which is to be yourself, and let the ace or the role player do their job, which is to give as truthfully as possible a patient with a variety of symptoms or conditions. And if they look in pain, ask them if they've had pain relief. Please ask them if they've had pain relief. You know, as Mark says, forget that baggage from the last station. I often tell students, and this seems to work for some of them, I'll say, okay, you've just finished that station. Put a delete button in your head. Delete, delete, delete. New station, clean screen, start again. It's like a new sheet of paper. Because whatever happened in that station, you can't change it now.
Absolutely. One of the things I find with perhaps PA students in the early days of their training, when they're more focused on remembering the sequence of a clinical examination that they're about to perform, is that they often lose a bit of their personality and they turn into a bit of a robot for the assessment, and they kind of use very formal language, perhaps even use medical terminology that they're not familiar with and don't know the definitions of, but they know that that's what they should say. Peripheral stigmata of disease or that kind of thing that really doesn't mean much in the general day-to-day world, but they've heard someone say it on an OSCE video somewhere.
Yeah.
And you can see as they get more competent at why they're doing the exam, as the course goes on and towards the end of their 2 years, they become more themselves, more natural. They speak with their own voice.
Yeah, pick up on that, because one of the things I'm always banging on about to PhD students is bringing yourself to the table. You are yourself with your set of skills, you see. And like you say about that being a robot, and coming back to Bob's thing, I've done a lot of suicidal ideation scenarios. And the way I've been dealt with sometimes has been that robotic program way. Like you say, they come out with things that they know, or they think they know the National Assessor will love, for example. But in fact, what I want in that scenario when I have a suicidal ideation is a human being who cares about me for that 10 minutes and wants to support me. And to be honest with you, the clinical knowledge and it just goes out the window, really. What I want from the PO would be a caring human being who wants to support me at that time.
I always ask them, I always say, what led you to do this profession? Was it to take care of people? And predominantly that's what people say, yeah. They want to care for people and help them. And I said, just remember that. Remember your purpose. Your goal is to pass the OSCE. Yeah, we know that. Your goal is to become a PA. We know that. What's your purpose? What is the purpose behind that goal? And I think if people stay on purpose, you tend to achieve your goals. So when something does go wrong, it's not the end of the world. And this is the other thing. Making mistakes is great. This is how we learn in education. You make a mistake, you learn from it, and you move on. And students are often afraid of making mistakes, particularly with an academic. With an ace, strangely enough, we're like their friend. We're like a confidant. And we do act as confidants with quite a lot of aces over the years. I have. Because they feel they can trust me. And I think Mark and the other aces that we have working for us will say the same thing. They confide in them about their worries, their concerns about exams and things that are going on long before they go to the academic. And the academics aren't big and scary. they're part of the team. We try to tell them that. But nevertheless, they feel more comfortable being able to talk to us and and to expose themselves in terms of making mistakes. They don't feel stupid, because we don't allow that.
When students come out of the classroom for the first time, they go suddenly onto the wards for the first time and do it on a real patient in a real hospital bed or a GP surgery for the first time. And they suddenly realize, oh, this patient's actually going to have pathology. They can have something wrong with them that I might find. They're a real human being who doesn't know the script I'm about to go with them and do on them because they've never heard the script before. We've never practiced it before. They just expect me to do an examination upon this patient. And then they start to freeze and they start to realize that they're actually working with real people. And it's quite a big transition for them to make that jump, isn't it?
Oh, yeah, absolutely. I mean, we do have some of the ACEs with pathologies. I think every human being has some pathology, unless they're really lucky. So, for example, I've got pathologies in my hip and my knee, and somebody can actually see and feel for the first time what a varus deformity looks like, what a fixed flexion deformity actually looks like, and what it feels like when they palpate, when there's a loss of joint space. We can simulate other things, like pain in the abdomen. Obviously, we can't simulate a swelling in the abdomen unless we've actually got that.
Sure.
But pathologies are not a tricky one, but we can go so far. And I mean, we have access to someone who can do moulage, for example, which is it's like makeup, special effects, if you like.
Putting my educational hat on, from a university's point of view, I mean, it sounds, if I was a student, it would be absolutely brilliant to have access to this level of simulation and expert patient actors, ACEs, to work with and study with and learn from. Is there, do you think, a reason why it's not offered across the board with universities and medical education? And do you think it should be changing in the future?
I think it will change in the future once people realise the value, but it comes down to money, James. All the clinicians I've spoken to will say the same thing. Oh, it's just down to funding, Bob. It's always down to funding. The students would say, well, I'm paying £9,500, so, I'd like a piece of that action. But it's not down to them. I mean, I know funding is quite difficult. The NHS is suffering anyway, and education is going the same way. But it's always down to funding. I think universities who took us on, like Chester and Wolverhampton, their clinical leads already had an experience of having been students who worked with ACEs. So they could see the value immediately and then sold that idea on to the fund holder. But sadly, it just comes, as always, James, it comes down to, have we got the money for this? Is it worth investing? I know there's a couple of guys who are doing their PhD on this type of thing, and they're building a body of evidence, because at the moment it's just hearsay. It's just just simple feedback from students. But obviously, medics being medics, you want evidence. Of course, you want evidence, and I understand that. So I think once the evidence is on the table, as it were, I think it will get bigger. It will expand.
If people have listened to this episode and have got questions or are interested in finding out more about Meducate Academy and the associate clinical educator role, where would you point them to go to find out more?
Okay, so I do a fairly regular blog post called associateclinical.educators.com. I mean, I've done articles in there on, how to fail your OSCEs as opposed to how you pass. Just a sort of a comedy article with a real intention. So I tend to update that at least twice, sometimes 3 times a month with interesting facts and information. There is also the YouTube channel. At the moment, we've got quite a large body of musculoskeletal examinations on there for the PA program. But I'm going to start building up GI, respiratory cardio. So the students will have another resource after they've finished with us. So that's the YouTube channel, Meducate Academy. And that's MEDUCATE, Meducate, educate with an M in front, Meducate Academy. So, I mean, essentially, yeah, if people want to get in touch with me, they can get in touch with me through both of those. As well as I'm on Facebook. We're on Facebook. Meducate Academy is on Facebook. We're on Instagram, and we're on Twitter as well.
Perfect. Thank you, Bob. Thank you, Mark. Thanks both for joining me.
Thanks, James.
And I'll leave links to your blog and your social media in the episode notes of this show so people can find it on their device and go straight through to what we've been talking about there. And thanks to you for listening as well. I hope you found that really interesting to find out more about simulation in medical education for physician associates. And if you'd like to get in touch with me for ideas on future physician associate podcast episodes, or if you're doing something really cool with PA education and you'd like to come on the show and talk about it, I'd love to hear from you. Please get in touch. I'm on social media at PA Podcast UK. And I hope you will join me again for the next episode.
Thanks for listening to the Physician Associate Podcast.